Hi, everyone. My name is John Faulkner, and I'm your host of the Smarter Systems, Better Care podcast. I'm here today with Roy Cohen. He is the co-founder of Behavidence, a mental health platform for screening and remote monitoring using digital biomarkers. Thank you for joining the podcast today.
Thank you so much for having me, John.
Absolutely. And just to give our listeners context, kind of get us kicked off, tell us a bit about your background.
So I actually grew up in a different industry, completely different industry, worked for 20 years in various aspects of the advertising world, worked in most of the big names in the advertising world. I had my own agency. I sold it at some point. I always had some kind of affinity and tendency to deal with biology for many reasons. I just felt attracted to this. But after 20 years in ads, I came to the opportunity to work at Facebook. Joined Facebook before it was Meta back in 2014, and I've been there for 5 years, which was a life-changing experience in the best possible way. I can talk for hours just about my experience at Facebook. Love this company, love everything they're doing. But the last 2 years of my work at Facebook, I used to work with advertisers and figure out how come Facebook's algorithm knows better who's going to buy their product next, better than any decision that they could make. And, in many cases, marketing manager are coming with some kind of a decision or some kind of knowledge about who the target audience is. And usually it's like 5 criteria. It would be like male and female 18 to 35 using this or that with some kind of a demographic definition. While Facebook looks at so many behavioral patterns of what you do inside Facebook, what gets you engaged, what doesn't get you engaged. And based on that, when Facebook makes a decision that, I don't know, this latest mobile device is the right one for you, John, it makes it based on so many criteria that usually it gets it spot on. And like people have this tendency to notice that you're thinking about a new car and suddenly your feed is full with new cars ads. You talk about, I don't know, a friend from primary school, and suddenly you see a suggested friend, that friend from primary school. And the thing is, people tend to think that Facebook listens to them. Facebook doesn't have to listen. We spread so many behavioral crumbles around us that just training a machine learning model can do a really good job at predicting who's going to behave in what. And that led me to pursue a master's in neuroscience when I left Facebook. I decided that I was dealing anyway with human behavior in general. I've listened to a podcast with Professor Moran Sir from Northwestern University, and he did something quite similar. He was a software engineer and a hacker of sort, and at the age of 34, 35, he decided to pivot his life, did a master's in neuroscience. Now he's like a magnificent professor, one of the leading researchers in computational neuroscience. And I'm like, so probably I can do it as well? So I just jumped into the water, and that goes in parallel to my father being diagnosed and treated for major depressive disorder for 30 years. 30 years is a lot of time and also a lot of medications that he went through. And in some cases, it looks like trial and error, and we're trying to figure out what's working, what's not working. So I entered this master's degree in King's College London, and it focuses quite a lot about on psychiatry and mental health and the boundaries between biological definitions to behavioral definitions to just collections of symptoms. And the more we got to dive deeper into that, I became agitated and anxious. And I remember clearly one slide that presented the results of a meta-analysis that was done in the US that made me stop the class and just leave that class. And it showed, it was a meta-analysis that covered 120,000 patients, and it checked what are the chances of the same patient to get the same diagnosis from 2 different psychiatrists. So, for example, you're getting a general anxiety disorder diagnosis from one clinician. What are the chances that you'll get a general anxiety disorder diagnosis from a different clinician? And for major depressive disorder, which is what my dad had, and also it's defined by the World Health Organization as the non-communicable disorder that costs humanity the most, more than any other non-communicable disorder. And the chances are below 30%. And people hate when I say it, but literally tossing a coin will give you better chances and better accuracy. So I'm like, what are we dealing with? It's ridiculous. And that pushed me to the place where I am today, which is in very simple terms, create the Facebook algorithm for mental health. So using the same principles to detect mental health disorders rather than predict what you're going to buy next or what friends you want to see. And this is sort of the background that led me to start Behavidence as it is today.
That's an amazing story. And the statistics, like you said, are like better coin toss. So, I did not know that. So that's some great insight. And what are specific solutions that you solve with Behavidence?
So we create then there's a debate about that, either digital phenotyping or digital biomarkers for mental health. So what it means is that we develop an app that sits on the patient or user, it doesn't have to be someone with a diagnosis, on the device, and it collects a lot of behavioral data. But unlike Facebook, it's only the identified data. So we're looking at patterns of how frequently you would open specific apps on your phone, how frequently you'd use your phone or turn it off or step away from it, without getting into what you're doing inside the app. We don't care about where you browse, what website you're looking at, what friends you're looking at. We never get access to that. And that by itself creates around 300,000 data points per patient per day. That's a lot of behavioral data. And when you think about what a clinician is doing, a psychiatrist, psychologist, even your GP, they look at a lot of behavioral patterns and they try to make some kind of a decision. But most of it is based on what you're reporting. So it opens the room for biases by you as a patient, but also by the clinician. We're removing all that. So we're basically listening to the behavioral data in the background, not listening with our ears, but recording a lot of behavioral data. And then we trained machine learning models to detect specific disorders. So, for example, I'll get into a glimpse of how we developed the depression model. We recruited about 4,000 people, and we surveyed all of them with the PHQ-9. PHQ-9, the patient health questionnaires, is one of the most common questionnaires you'll get as an intake, whether you're a mental health patient or you're going through an orthopedic surgery. You'll get that questionnaire up front, 9 questions that are trying to figure out if you have depression, underlying depression, and what's the level of it. So we sampled those 4,000 patients with the PHQ-9s, and then we collected behavioral data from their phone. And then we told the machine learning model, okay, those are all the positive cases that scored depression with a PHQ-9, and those are all the negative cases that scored no depression at all. And then you help the machine basically build an algorithm that will identify subtle changes in how you use your phone to detect depression. And that is happening on a daily basis. So now we have those digital biomarkers for depression, anxiety, ADHD, stress, PTSD, suicide risk, and postpartum depression. And what that means is that each of our patients and their clinicians, there's usually a clinician involved, is getting a score for each of the disorders that I mentioned between 0 to 100% on a daily basis. So, for example, my dad will receive a score between 0 to 100% for depression every day. And 100% means that the algorithm is confident that the last 24 hours, my dad was behaving as a depressed patient. It doesn't necessarily mean that this patient is diagnosed with depression. It just might mean that you're having a bad day or that you're developing a negative mood. If you get 0, on the other hand, it means exactly the opposite. The algorithm is 100% confident that you're nothing like a depressed behavior in it, and probably you're having a great day. If you're getting 50, it means that we don't have enough data to make a decision and the algorithm is on the fence. But the fact that you're getting those daily scores helps psychologists, social workers, psychiatrists to monitor day by day. And then when you see a patient, for example, 3 months after they got a diagnosis, you can go back in time and say, oh, what happened 2 weeks ago? I see a sharp rise in your anxiety levels. And the patient in many cases forget when they see what happened 2 weeks ago. And then you can go back in time and say, like, oh, you know what? Actually, I watched this TV series about a war that I attended and it sparked my PTSD. And that was 2 weeks ago. I stopped taking my medication for some reason. It's really adding clarity to how the clinician sees the progress of the patient.
And it sounds like it's provoking them to ask questions based upon the data that they're seeing and trending over time.
Yes.
Correct? Yeah.
Yeah, 1%. And it also allows them to automate a lot of things. And this is a feature we developed after talking to a lot of our partners. So today, usually we're working in sort of time lapses. So you see a clinician, you get a diagnosis, they ask to see you 3 months later. Some patients don't need to be seen 3 months later. Some patients need to be seen next week and not in 3 months. So we help them automate a lot of things based on our passive scores. So the scores are generated daily. The patient doesn't have to do anything. They don't have to use the app. They don't have to activate anything. So we can help them, for example, if you want to send them a questionnaire, so you can automate and say, like, if this patient has over 80% similarity with depression, send them a PHQ-9 questionnaire. If the PHQ-9 is called severe, invite them to the clinic. And all of that is now done automatically instead of trying to call and hoping that some of them will answer. But they can also automate sending them resources. So in many cases, mild depression or mild anxiety doesn't require a pharmacological intervention. So you can send them resources like meditation and mindfulness and automate that. So if this patient, or in some cases, we have some clients that are employers, so you can automate that if an employee develops a bit higher levels of stress or higher levels of anxiety, you send them a link to schedule a yoga class or go out for a run or even suggest taking a day off. That can also happen. So we allow them to automate a lot of, and most of these companies and clinicians, they already have the intervention. So we help them to automate it so it appears at the right time to the right patient and not sort of a one-size-fits-all approach to that.
And when you're looking at the industry too, just curious to get your perspective as well. What are most leaders not paying enough attention to with this that you're seeing?
So the key thing, and I think that led to the decision on the early days of Behavidence, we do not develop any intervention by ourselves. We are just the measurement. We're like, I love calling it the Google Analytics of mental health. If you look at the industry, there are thousands of startup companies or pharmacological companies that develop solutions for mental health. And you read this all across the headlines that we're dealing with a mental health crisis. It's a bigger pandemic than COVID. And like, how do we know? We never stop measuring what's the real size of the problem and also who needs attention and who doesn't need attention. And I think most of the leaders and even the investment bankers, and if you look at the general industry around mental health, people are looking at the wrong place. We're trying to plug so many solutions while we never ask what's working and what's not and for whom. And I think this is the key thing and when we started this journey, we had about 4 competitors. Now we are alone in this field. And I must say that it's depressing. It's depressing because there are so many solutions. We have no clue if they're working or not. And we continue developing more and more and more solutions without realizing that no one is measuring the effect. No one is measuring who really needs this solution at what point in time. And I think this is the key challenge of this mental health industry in general. And that includes, by the way, not only the tech companies, it includes the pharmacological interventions. If you look at antidepressants, we now have hundreds of thousands of patients in the US that are being prescribed 3 medications and more for mental health. In most cases, it's because the first medication didn't work. And if you are familiar with SSRIs, which is the most commonly prescribed medication, in most cases, it won't work as first line of therapy. And then you augment another medication. Sometimes it's a dopamine enhancer or an atypical antipsychotic. And then you augment ketamine on top of it. And this patient is now a drug addict sponsored by the insurance. And the biggest challenge of this is that we're not sure what's the underlying condition that we're really dealing with. So we're trying everything. It's like, pulling all the plugs, just trying to figure out which one is connected to the light source that we want. We need to change that. We cannot keep playing this guessing game and on one hand scream that it's the worst crisis that humanity is having, but refuse to measure it or refuse to better define it than it is today.
And, what's working really well in your team right now that you would never want to lose as well? Curious to see. It sounds like you're really stumbling upon some amazing insights. So just curious about the inner workings and how you're feeling about things.
Yeah, I think there's something beautiful about the team of Behavidence that we are slaves to the data.
Yeah.
Unlike a lot of other studies that have been done in this field, where there were a lot of biases, all watching patients not in their natural environment. And there are a lot of challenges with that. And for us, I remember that in the early days, we met with 2 Ivy League universities and quite a big provider health network. And we talked about ADHD. And they said, of course, with ADHD, it's easy to detect it via phone because you expect the patient to switch frequently between apps. And I remember the 3 of us, the 3 founders sitting there, I'm like, not necessarily. Why are we deciding that? Say, oh, there are studies that show that. I'm like, but these studies were people in robes sitting in a lab watching people and how they use their phone. And we did a study about ADHD, and actually we found so many different patterns in people with ADHD and how they use their phone. Some of them actually include less frequent switching and longer sessions in specific types of app that actually compensate for the dopamine seeking behavior. But I think that's one of the most brilliant things about the Behavidence team is this like slaves to the data and taking this as far as anyone has taken it so far. And I'll say something that I probably will regret, but most of the team worked for more than 1 year without getting paid. And the reason is because each person on our core team has such a strong conviction about what we're doing. And each one knows a case of someone personally close to them that suffered from mental health disorders, one or the other, and the treatment wasn't good enough, or the treatment wasn't offered in time, or the diagnosis was switched again and again and again and again, and they call it comorbidity, but it's just lack of accuracy. So everyone is obsessed with a mission and where we're taking this.
That's amazing. It sounds like you got a really invested team and everyone's going 100%. And that really is a testament to them as well and yourself.
Otherwise, we won't be here. You need
Yeah.
this conviction and you need this sort of passion to solve the challenge that we're solving.
And then looking down the road, where do you want to be even in like 6 months from now? What's your goal?
So I think I said it like being the Google Analytics of mental health. I want to make sure that everyone is using this as a measurement tool, whether it's a Talkspace or BetterHelp that offer a therapy, whether it's a small clinic with a psychiatrist in the middle of nowhere, whether it's a rural village in Africa and you have families that are using like one phone for 4 different people. To help everyone get better exposure and know better about their mental wellness and to make it accessible for everyone, regardless to what device you have. And I think this is how we use to price the product to make it available for everyone. And it doesn't matter what type of economy we're dealing with. And this is why we developed it not only for the most sophisticated iPhones, but also for the lousiest old school devices that can barely run a call and a messaging app. So I think this is where I want to be. And hopefully by the end of 2026, we'll have new, more biological in nature biomarker. And we're already seeing initial signals that we can detect dopamine levels in the brain just by using a phone. And we have an infrastructure to measure serotonin just by using a wearable device. And I think once we get there, it will help the scientific community to start reclassification and better nosology of the mental health sort of book of disorders, like the DSM-5.
And your platform or your solution, is it available today as well for use, or what stage are you at, just to give our audience context?
So yeah, it's available for everyone. We're partnering with clinicians, with hospitals, with payers, insurance, with employers. I think more than anything else, our greatest traction was with governments. We're working with 3 governments, mostly around suicide. We showed clear evidence that we are able to detect suicidal ideation with 85% accuracy.
It's amazing.
In most cases, governments already employ the resources to treat it, or to intervene, or to call, or to contact you, or to help you when you develop suicidal ideation. Clinicians, like a small clinic, won't have the ability to do so. Think about it. You have 2,000 patients. If Behavidence alerts you this patient is suicidal, you need to act very quickly. Otherwise, the liability is quite concerning. Governments have the resources to do with it, and this is why our biggest growth comes now from governments. I really hope that by the end of 2026, we'll grow as significantly as with governments, with small clinics and HMOs and networks of clinics, because I think we can help them solve it better as well. Not only the aspect of suicide, but also the remote monitoring and accuracy in diagnosis.
Yeah, and thank you for sharing. It sounds like you're making a huge impact in the 85% that you mentioned. That's again, just testament to what you're working on and the impact that you're having today. And, where can people find you to connect if they want to learn more?
So the best way is probably on LinkedIn. I am available in a couple of other social networks, but LinkedIn is the one I respond to the most. Or you can just send an email through the Behavidence website. It's behavidence.com, and it either gets directly to me or it will get to me through our operations team quite quickly. But I'm always happy to meet and talk to anyone who has this passion for this industry, and it doesn't have to come from a professional passion. We have a lot of patients that wrote to us that they're fascinated by how it measures the effect of the medication.
Yeah.
So yeah,
Well, thank you for your time today. It was a wonderful discussion, and I look forward to spreading your message for you on the podcast.
brilliant. Thank you so much.
Yeah, thank you.
Thank you.